Hello, this is David Bishai, and this is our lecture on managed care. Managed care really started early in the 20th century, started not just at the Kaiser Permanente company. There were other companies that were similar to Kaiser running in parallel. The Kaiser story is emblematic of how this industry started. It starts from a businessman. Henry Kaiser's running a construction company. He has thousands of workers. He has to offer them workman's compensation benefits. There were a lot of private companies he could have gone to buy workman's comp insurance, but he decides to self-insure for workman's comp. So he holds on to the insurance money. He puts aside a fund inside his company. This is going to be his workman's comp fund. He calls his internal in-house subsidiary the Industrial Indemnity Subcorporation. That subcorporation now contracts with the local hospital to serve the workman's comp needs of 5,000 construction workers inside Henry Kaiser's company. He pays out the hospital $1.50 per month to the hospital, flat fee, says you're capitated now, take care of my employees for any work-related injuries. The hospital that gets that capitated payment now feels an incentive to work with Henry Kaiser to try to prevent workman's comp. It's capitated. It loses money every time an injured worker comes in and starts to manage the employees and manage the industry's exposure to injuries. Because it's an in-house company, the capitated subsidiary, this capitated hospital, can't pass back the injury costs back to the payer. If there were an outside hospital saying, you know what, your injuries are just costing me too much, I'm going to raise your capitation rate, I just can't handle $1.50, people are too sick and too injured, I need $2 per month. That's not going to happen to Henry Kaiser. It's his own company, so he's going to try to manage the risk. Now, over time, the benefit package grows out of just workman's comp. It starts to cover everything, soup to nuts, health care, disease care, and the customer base grows outside of just serving Henry Kaiser's own employees to going out to the market and saying to other companies, we will become your insurance plan for your employees. They offered really exciting branding. They called this industry, the industry of health maintenance organizations. It's a beautiful phrase. We're not to take care of your sickness. We're here to maintain the health of your beneficiaries. So there are the same incentives of capitation that you're well familiar with. The person with a capitated contract wants to control costs. They want to compete on low premiums. So the health maintenance organization industry was famous for cost control and low premiums. In the 1970s, people started to look at the cost control as a major problem for America. This is under the Nixon administration. They were looking at those near double-digit healthcare cost growth, and the federal government says this is a national problem. Look, it's going to chew up all of our GDP per capita. We've got to control healthcare costs. Edward Kennedy starts talking to Richard Nixon about what could happen, and they've got their eye on the HMO industry on the West Coast. And so the HMO Act of 1973 passed, and it says to American firms, if you have more than 25 employees, you can keep your old health insurance plan, but you have to add on the option of an HMO plan. This is a big boost to the HMO industry, because now every firm in America needs to put them on the list of options to their employees. And HMO companies start forming and supplying a lot of options. At the same time, the formats of the HMO, from this closed in-house, we offer all of the insurance, we offer all of the hospitals, all of the doctors, that opens up to varieties of HMO options. So many varieties of managed care were allowed after 1973. The health maintenance organization, the Kaiser-style example, which was a vertically integrated system, insurance is tied to all of the hospitals, all of the salaried doctors, all of the formularies, it's all in-house. That's still on the list in 1973. But also allowed is something called an independent practice association. That's an HMO in which a single doctor group serves the HMO but isn't tied to that single HMO. They're allowed to see patients from around. So we've broken up that complete vertical integration of the doctor group and the HMO with an independent practice association. In a preferred provider organization, there are multiple doctors, multiple doctor groups that are contracted in. So instead of an IPA with one doctor group, a PPO, a preferred provider, has multiple doctor groups competing and bidding to have a low cost to serve the HMO. And in a point of service version of MCOs, the doctors are going to accept capitated rates as they compete with each other. The MCO boom starts in 1973. These forms of managed care start to pervade the American health insurance industry. And we're now seeing most U.S. health insurance plans are now establishing provider networks, hospital networks, managed formularies. They are not saying, come to us and you can see anybody you like, take any drug you like, any hospital you like. They are contracting within a subset of the providers, hospitals, and formularies. So that alone, as you'll see, helps them control costs because they get to negotiate with the provider market. They also have many other ways to control costs, and let's go over the ways that a managed care company controls its cost. It can actually manage care. It can gatekeep and get second opinions, and it can manage the formulary. That's one way to control cost. Managed care companies can cherry pick healthier patients, and it should be clear from our prior study of capitation and adverse selection that offering hassle-ridden, lots of hassles, low premiums is a way to make healthy people want to take your insurance. It can incentivize providers to try to control costs, and as we've mentioned, it can consolidate its purchasing power and bargain with providers to get those rates to be low. How to control costs? You can manage care, you can capitate, cherry pick, give provider incentives, and you can negotiate with your providers to get their rates down. So let's talk about this branding. What is a health maintenance organization? The branding says that this will be an insurance plan that is a producer of health because we're incentivized to keep people healthy. We will keep them healthy and they won't cost money. That's the business case for making people stay healthy. However, as you know from studying health economics, health production requires the agent to demand health. If the agent doesn't demand health from their Grossman model of health production, they won't do things to make them healthy. They won't exercise and they won't eat enough health food. So can Kaiser make somebody demand health? Unclear. What in your model of health demand says my insurance plan will make me want to be healthy? The opposite, a health insurance plan says, oh, good, I can get coronary artery disease, and now that I'm insured, the cardiologist will give me a stent. Can Kaiser alter the prices of health inputs? Yes, it can. So one of the things you should expect managed care to do is to make it really cheap to get a vaccine or a preventive cancer screen or membership in a health club. Kaiser should try to lower those prices to try to make you healthy and stay out of their hospital. Can Kaiser alter the social determinants? Can it fight systemic racism? Can it fight poverty? Can it fight blighted neighborhoods with liquor stores on every block? Unclear. Kaiser is working on it. The jury's still out on how effective that they will be. So in the Rand Health Insurance experiment, we did not see any evidence that managed care caused the members in the Rand study to have better health. No evidence of that, but again, it was only a 5-year study. For sure, the managed care companies had lower costs than fee-for-service with no copays, but they had the same costs as fee-for-service with copays. So we're not getting from the Rand experiment that managed care makes you healthy prospectively. When we look at the reality of what's happening in managed care, we see that there is a reality of gatekeeping. Patients in managed care are not allowed to just see any specialist they like without a referral. The primary care doctors, like internists, will manage your depression. The pediatricians will manage the allergy shots instead of sending you to an allergist week after week. They will substitute lower-priced primary care for a high-priced specialist. They'll demand second opinions for procedures, which also limits supply-induced demand. No evidence that second opinions save a lot of money because of collusion between opinion number one being the surgeon who knows the surgeon who's giving the second opinion. But still, there's this often a requirement for second opinions to gatekeep in managed care. There are managed formularies. So if you have a managed care plan, you're not going to be able to order any drug with the same coverage. You get a lower copay if you hire a preferred drug than if you, and a lower copay if you buy a generic drug. And there are still a few copays inside managed care. There is evidence of cherry picking in managed care. We see when we look at the new enrollees in a managed care company that they are way cheaper than average. They have 20 to 30% lower costs than average the year before they sign up for the MCO. They look cheaper and they stay cheaper after they go into managed care. And the explanation is that the managed care company is out on the market, says, look, we have really low insurance premiums, and you know we're managed care. You're going to have some hassles. You're going to have gatekeeping. You're going to have these people getting in your way when you want to see a specialist. So you're going to pick the managed care company if you think you're not going to need a specialist. So they will cherry pick based on advertising low prices and hassles. And the healthy people who know they're going to be sick, they're not going to go to the hassle. They're going to pay more on their premium. And so we have adverse selection happening as we segment the market into the managed care market as well as those that still maintain fee-for-service. There are some provider incentives in managed care. There's physician profiling that offers incentives to lower costs. There are holdbacks where the providers are not given all of their payments unless they meet a cost target, and then they're given the full payment. Managed care incentivize high quality. They will give you a bonus for meeting quality measures, and they will select providers based on quality. So that's something that they can manage. Important point about managed care, and this is pervading the entire healthcare industry now, is bargaining power. To start an MCO, you promise premiums that are lower than the competition, you get large numbers of patients, and you tell doctors and hospitals that you won't sign with them unless they give you a 20% reduction in their fees. And you play hardball. You say, you want to see my patients, look at all my 10,000 patients. You're not getting any of them unless you give me a fee reduction. And then the cycle continues. Lower premiums, more patients, more bargaining power, more lower fees, more lower premiums, and you can play that off in a cycle. So questions about bargaining. Do payers use bargaining power to negotiate for better quality or just lower fees? Why not both? Why not ask your doctor groups to meet the quality targets? And the answer is yes, they are using bargaining to do both quality and fees, but it's a market, and one can't expect the incentives to drive the same degree of concern for better quality. It's harder to measure quality. It's easier to measure fees. The other thing to expect is that the doctor groups and the provider groups ought to also be consolidating their bargaining power. We should expect private providers to consolidate in order to bargain back to managed care. And they should tell insurers, we will tell our patients not to sign with your company unless we get fees that are 10% higher. Now, that runs a little bit up against antitrust and trade associations, but bargaining from the payer side has led to bargaining by the provider side. So hospital networks and large doctor groups are the landscape in American healthcare now as a result of getting back to bargaining. If you have high power bargainers on the managed care side, you have to consolidate on the provider side to bargain back. So let's summarize. The U.S. has a public and private healthcare system. It has the world's highest per capita healthcare cost per person. It has the highest cost growth, been higher than GDP growth for most of the last 50 years. The cost growth is dominated. Why is it happening? High prices because technology is more expensive. Intense health technology has come to America. Great if it has made us healthier. However, American life expectancy is lackluster and not as high as countries that spend a lot less and have less high tech. So lots and lots of tech in American healthcare. We're not seeing it drive our life expectancy higher. We'll talk about why that is. Why aren't machines making us live longer? I think you might see the answer if you think about it. Medicare and Medicaid are large federal programs that are here, and part of what they want to do is cover more people, but they also have been facing the problem of rising costs. They've used DRGs and capitation and managed care as instruments to help drive down costs. However, as an unintended side effect of DRGs, we've seen an incentive for hospitals to chase high tech. They are not restrained in their ability to access capital, and so they've been shifting from high labor costs into high capital costs to take care of sick people inside the hospital. They've been shifting care to outside of the hospital, but overall we've been seeing this drive to high-tech medical care. Managed care was brought in America in the 1970s to help restrain costs. It is successfully holding down its own costs. However, we are suspicious that a lot of the cost control in managed care is cherry picking, which doesn't really restrain all U.S. healthcare costs. It just simply gives the managed care company with low-priced customers lower costs. The managed care success is also driving bargaining power, and so we're seeing this war of managed care consolidation and bargaining power coming up against healthcare providers that have to bargain back. So that ends our lecture on the U.S. Healthcare system's approach to healthcare cost control. We'll be seeing you back for further lectures in health economics.